Hi, everyone. My name is Winnie Elias. I am an orthopedic nurse over here at Orange Coast Hospital. I'm also the ortho navigator. As a navigator, I act as a point of contact for patients who are coming in for surgery. And this is a process that starts even before coming into the hospital and continues even after you have left the hospital. We are so glad that you've decided to stop by and listen to the good information that we have for you today. We value your time and we hope that you'll find this information helpful as you prepare for your surgery. We have been doing this presentation for the last, I would say, more than 6 years now. And our observation is that the patients who come to getting the information beforehand tend to do better. They come in more prepared for their surgery and their outcomes are normally better. So we are so glad again that you took your time to come and listen to the information that we have. We also realize that there are so many other places that you can get this information. You know how to go on the internet. But I think by the end of the day, it matters so much the type of information you're getting out there. The information that we have for you today is all evidence-based information, which means we have an explanation as to the way we do things. And the things that you're not going to find in our program, we also have an explanation as to why we do not do them. So it's more of evidence-based practice. I will be doing the first half of the presentation today, and later I'll be joined by Alisha, who is our physical therapist that deals with patients who come in for spine surgery. Before I go further, I would like to tell you more about our program because we are so proud about what you do here at Orange Coast. Our program has been very successful, so much because of our philosophy. And our philosophy is that you're not sick. You are a healthy person with an unhealthy back, whether it's the lower back, the lumbar, or the upper spine, which is the neck or the cervical. So when you come into the hospital, we are going to treat you as a healthy person. You're a healthy person, but has an unhealthy spine. So you come into the hospital, you get your spine fixed, we get you up, we get you moving. For a long time in healthcare, we used to keep our patients in bed after surgery. But evidence or research has shown that patients who don't get up, they are more likely to get blood clots, they are more likely to get pneumonia. So physical therapy for our patients here at Orange Coast begins on that very day of surgery. We are not asking for you to do so much. It could be just standing up and sitting down. Or you could stand up and take a few sets by the bed. Or you might stand up and pass out. I mean, there's a wide range of how much you can do. What we are asking is that you try, don't say no. Because again, getting up and moving around will help towards your recovery and prevent those complications that could arise as a result of you not getting up. The other piece that you're going to find in our program is that our patients wear their own clothes. Remember, I said you're not a patient, you're a healthy person. The days of wearing those drafty gowns that always open to the back are gone. The following day after your surgery, we expect for you to be dressed up in your own clothes, something easy, something comfortable. How about basketball shorts and t-shirts? And for my ladies, you may wear something like a PJ, something easy, something comfortable. We just don't want you to come in skinny jeans or something that is difficult for you to put on and off. You want something that you're going to lift up and down, maybe a bottom with an elastic band, something easy, something comfortable, nothing so fancy. If you're coming in for lower back surgery, we would expect for you to have maybe a two-piece, a PJ, because every so often we have to look at the incision and make sure that everything is okay. If you're coming in with a muumuu dress and all that, it's not very easy for us to access the incision area. So separates work much better. If you're coming in for neck surgery, you might want to bring something with a button down, like a button down shirt, or something with a zipper to the front instead of coming with a t-shirt. It's a lot easier for you to get on the top, whether it's a blouse or a shirt. So button down shirts or something with a zipper to the front. How many of those outfits are you going to bring to the hospital? And that takes me to the next question of how long you're going to stay in the hospital when you come in for your surgery. And this has changed as well. I've been working as an RN for a long time, and I'll tell you, just over the last 5-10 years, a lot of things have changed. Before, we used to keep our patients in the hospital for about 5, 6, 7 days. What we did not realize is that when patients stayed in the hospital longer than expected, they are more likely to get an infection or hospital-acquired infection. We call that nosocomial. Remember, you're a healthy person. In the hospital, we are taking care of sick people. Where do you find MRSA? You find it at the hospital. Where do you find pneumonia and all these UTIs? It's in the hospital because you're taking care of sick people. So if you come to the hospital and you stay longer than expected, you are more likely to catch any of those infections, and you go home and then have to come back again. So to minimize or to reduce the exposure, your length of stay has been reduced maybe to about 3 nights in the hospital. On average, our patient will stay in the hospital for about 3 nights. And we're going to talk more about that because it all depends with how many levels. Are you coming for a single level? We're going to talk about the level so that you understand much better. But if you're coming for a single level, probably you'll be staying for 1 night. If you're coming in for 2 levels, you could stay a little bit longer. And for that time, you are staying not because of any other thing, but probably because you have a drain, because we tend to use drains to get the drainage out. That might keep you longer in the hospital. But on average, again, we are keeping you in the hospital for about 3 nights. We are trying to minimize the exposure of other things that could cause you an infection later. We try not to use the Foley catheter. A catheter is a drain that is put in your bladder so that you don't have to get up to go pee. Again, in healthcare, we used to put catheters in everybody. Little did we realize that putting a tube in your bladder is going to expose you to UTI, urinary tract infection. Some of the people that got the UTIs, it wasn't just for a week or 2 weeks. It's been an ongoing thing. Every time they're tested, they have some bacteria in their urine. It's a chronic UTI. And this is because of a drain that might have been put in their bladder. So we are very careful on that. If you get a catheter, it's going to be there for about 12 hours. And that is usually for people who are coming in for lower back surgery. You get a catheter, we're going to come and take it out the following day after surgery. If you're coming in for neck surgery, there should not be a reason as to why you're getting a catheter. If you find one on you, ask the nurse in PACU or recovery, do I really need to keep the catheter? Because again, use of these drains unnecessarily is exposing you to a UTI. All our rooms are equipped with bedside commodes for my ladies. If you need to get up to the bathroom, we have a bedside commode, which is a portable potty that is put by the bedside. And all you need to do is to get out of the bed or sit on the commode. Or you can take a few steps and go into the bathroom. For our men, we do have a lot of urinals. You can use the urinal either in bed, or you can stand up and use it by the bedside, or you can go to the bathroom. So that eliminates the need of us putting a drain in your bladder that might probably cause a UTI or put you at a risk of getting an infection in your bladder. So we do not use Foley catheters. Another thing I think I should talk to you about is pain management, because I know you're going through pain, but you're also apprehensive. You're not quite sure that you want to go through your surgery because someone has told you that it's very, very painful. And part of that is true. But the way we manage pain nowadays is different than the way we used to manage pain in the past, or how we've managed pain in the past. I'm not saying that you're not going to have pain. You're going to have pain, but it's pain enough that you'll be able to eat, sleep, and move around. We haven't found anyone to do these procedures pain-free yet. So please be prepared and know that you're going to have some pain, but the pain that you're going to experience after surgery is unlike the pain that you have right now. Because the pain that you have right now is more permanent, and you know that for sure. You don't enjoy walking your dogs anymore. You don't enjoy, going shopping. You don't enjoy doing things in life because the pain is putting you down. Well, the pain you're going to get after surgery is a pain that is temporarily, it's going to get better as you continue to heal. Once the pressure is taken off the nerve, then the pain goes away and you are able to function like a normal person. But what are we doing as far as pain management here at Orange Coast Hospital? Number one, your surgeon is going to give you pain medicine in the pre-op area. Before you go in for surgery, you're going to get some pain medicine. We call that preemptive pain management. When it comes to pain, especially surgical pain, you always want to get ahead of the pain. So how do we achieve that? Is by giving you pain medicine before you go in for surgery, so that by the time you're waking up, the pain medicine is already on board. The other thing the surgeon is going to do is what we call multimodal pain management or combination therapy. And what that means is combining medications from different classes. For example, we can combine an opioid called hydrocodone or oxycodone acetaminophen. You combine that medication with maybe Soma, which is used for muscle spasms. If you use that medication in the appropriate dosages, you achieve better pain management. Or in some cases, the surgeon might combine an opioid with a non-steroidal anti-inflammatory just for a short time. We achieve better pain management that way than having to give you heavy-duty pain medications, because that is what we used to do before. We give you a pump loaded with all the drugs, like Dilaudid and morphine. We call those PCA, patient-controlled analgesia, so that you'd medicate yourself. And as much as that sounds like a very good plan, those are heavy-duty pain medications that can cause you nausea, or they can give you these constant headaches, especially with the Dilaudid. And altogether, those medications can make you loopy-doopy, which means you're not participating in therapy, which is not good. So we know of a better way to manage pain, and that is multimodal pain management, combining medications from different classes to achieve better pain management while still keeping you active so that you recover well. The surgeon might also give you some block or some numbing medication at the surgical site, so that you're without pain maybe for a good 12 hours. We see that our patients come in, have surgery, they are up and walking right away because they're still numb at the surgical site. Eventually, that numbing medication is going to wear off. But hey, you have taken advantage of that. You got up, you moved. So we tend to use that numbing medication, again, that will last for about 12 hours. I know some of you might ask, why don't you leave it there for a week? But again, what we have is up to 12 hours. And by that time, we have taken advantage of that by getting you up and moving you as much as you can. If we have done all that and we can still not achieve pain better management, we consult the pain doctors. We have a lot of pain doctors around. In the past, we never used to have pain management doctors. But right now, I can count like maybe 2 or 3, 4 pain management doctors that we can tap into. We've tried everything. We gave you some ice packs. We did preemptive pain management. We did combination therapy, and nothing seems to work for you. Well, we are going to consult the pain doctor so that we can better manage your pain. So again, there's a change in how pain management is managed. And I think I like what we have now than what we used to have in the past. Now, in a nutshell, those are some of the things that you're going to find in our program. And I'm going to expound more through the PowerPoint. The way the PowerPoint is set is in such a way that it's easy for you to follow. We are going to start with the pre-op, what you need to do before you come into the hospital. And then you're going to get into the intra-op or surgery just a little bit. And then you do the post-op and you talk about the discharge information as well. So in case you find yourself lost somewhere, just try to trace where we are and then join us and continue. If you have any questions, I need to provide you with a phone number so that you can call us in case you have any questions. And the phone number is 714-378-7264. Again, if you have any questions, you may call us back at 714-378-7264. Okay, I'm going to go ahead expeditiously to the PowerPoint now. And the objectives for today, or the reason we are doing this presentation for you, is so that you may know what to expect when you come into the hospital. We are going to talk about occupational therapy and physical therapy. We are going to talk to you about the things that you need to do as you plan for your recovery, which is kind of different because in the past, we used to prepare for recovery when our patients are in the hospital, which is not the right way to do. We know of a better way. We want you to prepare for your recovery and plan for that even before you come in for your surgery. We are going to talk a little bit about your procedure. I don't think I have to talk so much about that because I'm assuming your surgeon must or should have talked to you about your procedure. But again, we're going to touch a little bit of that. Talk to you a little bit about the pain management, which we call multimodal pain management or combination therapy. We're going to talk about how you're going to take care of yourself at home. We are going to talk about the role of a coach, and we'll also talk about the case manager. The case manager is the most important person because she's the one who is between you and the insurance for whatever you're going to need after you leave the hospital. For example, if you're coming in for lower back surgery, you might need a walker. Just so that you'll be able to walk safely. Where do we get a walker? Well, the case manager is the one to speak with the insurance and tell us where to get one for you, or have the vendor bring it here for you. Maybe you might need physical therapy or someone to come and check on you at home. Which agency do we use for that? The case manager, again, is the person that will speak with the insurance so that they can tell us which agency to use for your physical therapy, and everything is all set before you leave the hospital. Each one of you is going to have a case manager, and the process with the case manager begins when you get admitted into the hospital. I am taking the role of the program coordinator, and just like I said, I'll be available for you guys. If you have any concerns, even before you come into the hospital, after you leave the hospital, I'll be available. And even here at the hospital, I'll be doing my daily rounds. And we work in collaboration with the physical therapy, or I work in collaboration with the physical therapists, the case managers, and the nurses so that we have a safe discharge for you. Now, when you come to spine column, and I like talking about this because sometimes people have a lot of misconception. So it's good for you to have an overview. Now, the spinal column is made up of the three major portions. We have the cervical, which runs from C1 to C7, and that is the neck area. That area will service your hands, your arms. All right. And then after the C7, we do have the thoracic, the T1 to T12. That is the chest area coming down all the way to the upper back. And then after that, we do have the lumbar area, and that runs from L1 to L5. And then we have another fused joint that we call the sacrum. And of course, to the bottom, we do have the tailbone, which is the coccyx. Now, in my presentation today, anywhere you see the light blue area, that represents the disc. Onto the extreme right, we do have a picture there that shows, the lumbar. We do have the nerves that are represented in yellow. And of course, the blue, just like I said, is the disc. The disc as a shock absorber. It takes all the pressure. And our spine is the main core. If you have to move around, you are depending on your spine. Now, when I talked about being in the hospital, maybe for 1, 2 nights, 3 nights, I was talking about the levels. For example, if you look at the lumbar where we have the purple L1 to L5, for a person who is coming in for L1 to L2, that's an easy procedure. It can be done the same day, go home the same day, or you might have to stay overnight. That is different than a person who is coming in for L1 to L4 because those are 3 levels. It's a multi-level. Same thing with the cervical. You have C1 or C2 to C3, that's a single level. But someone who is coming in for C3 to C7 might be staying a little bit longer because it's about 4 levels. That's why I was saying it all depends with how many levels you're coming in for. Laminectomy is a decompression procedure. As you might have been told by your surgeon, the problem that you have right now is as a result of the nerves being pushed. There's some pressure onto the nerve. So the procedure is aimed at taking the pressure off the nerve. Some of those procedure, or one of that procedure that is done to decompress is the laminectomy. And sometimes they might combine that with a fusion, and we're just going to see that in a little bit. The pictures that we have for you there, we do have, I said where you see the light blue, that represents the disc. The disc acts as a shock absorber, and in your mind, I want you to imagine the disc as a jelly donut. So the jelly has to stay in the donut. Anytime the jelly gets out of the donut, then we have a problem because you're talking of a herniated disc, ruptured disc, or a bulging disc. Onto my left side, we are seeing the before picture. And what you see there onto the right, there's some redness in that area, which means that nerve is compressed, probably because of the arthritis of the spine, which we call the DDD. There could be some scar tissues, or maybe there's some wear and tear, and there's some osteophytes that are formed there, and the nerve is compressed. That is the picture before. But then when you look onto the right side, we do have another picture for after. And you can see the redness that was on that area, it's all gone. Now, this is a laminectomy. It's a procedure that was done to take the pressure off by removing part of the lamina. The lamina acts as a roof to protect the spinal cord. Now, on my representation, therefore, after, the incision looks big. Well, we had to magnify that so that you'll be able to see. But in real life, the gap is not that big. So laminectomy is a decompression procedure, and it's the removal of the piece of the lamina to take the pressure off the nerve. A fusion, when it comes to the lower back surgery, we are talking of posterior lumbar interbody fusion, or it could be anterior lumbar body fusion. It could be a combination of anteroposterior, which means they go through the front and the back. And there's another one called transforaminal lumbar interbody fusion. That's for the lower back. For the neck, we have the anterior cervical discectomy. And what that means is that the surgeon is going to go through the front, make an incision on your neck to the front, a small incision, or they could go through the back. Again, that is posterior cervical discectomy fusion. The goal with all these procedures, again, is to take the pressure off the nerve. Some other terms that you might have heard from the surgeon is probably a bone graft, and that could be a daughter bone or your own bone, and I'm gonna talk to you more about your own bone. There's also maybe some mention of hardware, titanium rods, plates, screws, or cages, and of course a fusion, which is pretty much creating a bridge between 2 or more vertebrae. What we have here is a representation of a discectomy. Discectomy on its own is a decompression procedure to take the pressure off. When you look onto that picture where we have the light blue, where the disc is, you can see the disc is bulging, it's herniated, and in the course of that is causing pressure onto the nerve. That's why the nerve is all red in that area on the right side. So that is a ruptured or bulging disc. Well, with all the technology, we don't have to make a very big incision to fix that. Microdiscectomy is a procedure that the surgeon is going to use to take that area that is bulging to cut it off so that it's not pushing the pressure onto the nerve. So what this is representing is a kind of a minimally invasive procedure. Again, with all the technology, nowadays they can do these procedures which are minimally invasive because we have advanced equipment, we have real-time x-rays that are done when the procedures is being done and makes it very safe and quick recovery for the patients. But again, a discectomy is a decompression procedure that will involve the removal of the ruptured or bulging disc material. Okay, the bone graft is a fusion, bone graft fusion, and the picture that I showed you earlier showed where the disc was bulging, and in the course of bulging, it was pushing onto the nerve. Well, your surgeon went in there and took the pressure off by cutting part of that disc. Well, if you don't put anything on that area to maintain the height, then you're going to have a problem. And that's why the surgeon is going to use a cage to restore the original height and improve stability of the spine. The spine is the main core. When you have to move around, to sit, to do stuff, you depend on your spine. So they have to make sure that the stability is improved and we are able to maintain the height of that spinal column. On to the extreme left, that shows an area where the surgeon was able to harvest the graft. If he's going to use your horn bone, then there's an area on your hip, we call it the iliac crest. In that area, the surgeon is able to harvest the graft and use it in the cage, and that will facilitate the healing. The mosalized bone is put in the cage, and the cage is being put in that area to maintain the height of that spinal column. On the extreme right, we are showing you a spine that has been fused. That area has been fused so as to immobilize. Again, just like I said, if we did a decompression procedure and just let you out go, then, well, what if you came back and something went bad? You did not maintain the height, or because of the repositioning or the fusion that was done or the surgery, you might mess it up. So what the surgeon does is to do a fusion, and that fusion again will help to immobilize the area of the surgery, whether it's on your neck or your lower back. After surgery, the surgeon is going to recommend a brace for the most part, especially for the lower back. Again, that is as a reminder, and the physical therapist is going to talk to you about that because there's some things you can and cannot do. You might have to wear a brace just so that you're reminded not to twist your back or not to move in a way that is going to mess the fusion. The goal with your surgery, again, is to lessen pain and restore functionality. Now, healthcare has shifted. We see more of patient-centered care, which means you as a patient will have some homework. You're the one to set up your goals, and we as healthcare providers, we help you to achieve your goals. So some things you need to do before you come into the hospital for your surgery is, number one, to make an appointment with your primary care doctor. It just should not be the surgeon saying you're good enough for surgery. How about your heart doctor? How about your pulmonologist? How about your kidney doctor? All those doctors need to sign you off and say that you're good enough for surgery. We also need to get some lab work done. And that is going to include maybe a white cell count. We want to check your hemoglobin to make sure that you're not anemic. We also have to check your potassium, your calcium to make sure that everything is okay. We also need to do an EKG. Why an EKG? Probably because you're over 55 years. Maybe you have hypertension, you have high cholesterol, you have congestive heart failure. It's very important for us to do an EKG and make sure that everything is okay. A chest x-ray, yes, probably because, again, you're over 55 years. Maybe you have history of COPD. Maybe you have asthma. Maybe you're a smoker or you used to smoke. Well, we have to do an x-ray to make sure that your lungs are okay. MRSA, that stands for methyl-resistant Staphylococcus aureus. But that is a fresh-eating bacteria that you normally find in the nostrils. And when you go for your testing, they're going to put a Q-tip into your nostrils and swab one side and the other side and send it to the lab. If it comes back positive, it's not a death sentence. MRSA is treatable. We just need to test that before you come in for surgery, simply because if it's in your nose, with the same hand, you might blow your nose and forget with the same hand and touch the surgical site. That's why you want to have the MRSA tested. Some people are healthy carriers, which means they have it there and it doesn't cause any harm. That is if they're not going to have surgery. But again, in the scenario that you're coming to have your surgery, you want to make sure that you've been tested and you don't have MRSA. Urine analysis, yes, we have to check and make sure that you don't have a UTI. I need to let you know that our rate of infections here at Orange Coast has gone down way below the benchmark. And I believe part of it is because we have our patients do all their homework, anything they can do to prevent getting an infection. So getting your urine tested to make sure that you don't come in with a UTI is very important. If you have diabetes, we recommend having the A1C to below 8. A1C is a number that is checked over a period like 6 months to show how your blood sugars have been trending. If you can get it to less than 7.5, that will be great, but I'll take 8 for now. And then the blood sugar, the one that you check before eating, we call it fasting blood sugar. We want that to less than 200 milligrams per deciliter. So probably it is time for you to monitor and watch what you eat. If you're already on medications and your blood sugars are skyrocketing to 300 milligrams, 400 milligrams per deciliter, it might be about time that you spoke with your endocrinologist or maybe your primary care doctor. Or you might want to modify your diet so that you can get your sugars under control. And what's the concern here? If your blood sugars are too high, you are more likely to get infected. That's why we want to make sure that your sugars are within the normal limits. Protein is very important because it does help with your healing. Things like white chicken is so rich in protein, things like beans, if you're vegetarian. Our goal here, or what we're trying to emphasize, is that you boost your protein intake. You have enough time, maybe when you're watching this video, you have 2-3 weeks before you come in for surgery, focus on improving your protein intake. If you can afford things like Ensure or Glucana or Boost, they have a lot of protein in them, and the protein cereal bars, if you could afford that, would be great for that 1 week, maybe to drink a can of Ensure or Boost. Again, we are trying to boost your protein intake because you're going to rely on that for your recovery. Hydration is very important. We have noticed that patients who come into the hospital when they are well hydrated, they tend to do better versus the ones that come in dehydrated. When you come in dehydrated, we see the blood pressure going down and patient passing out. Well, this is something that can possibly be prevented if you came to the hospital when you are well hydrated. From the nurse's perspective, I'll tell you, when you're well hydrated, I'm able to see your IV, so I won't have to stick you so many times when I'm looking for an IV. So all in all, we are saying stay well hydrated. If you could afford things like Gatorade, Powerade for those who have diabetes, or Propel, those are so rich in the electrolytes, although sometimes you have to look at the amount of sodium in each one of those, then you might have to dilute. But if you cannot afford these drinks, how about just the regular water? If you don't have any restrictions, like you don't have any congestive failure, or you're not a kidney patient, we want you to push a lot of fluids so that you come into the hospital when you are well hydrated. Iron intake is very important. And where do you get that iron? Things like beans, green leafy vegetables are so rich in iron. Liver, I don't like it, but it's so rich in iron. So again, the message here is to improve or to increase the intake in all these nutrients because they will pay back. If you're planning to have any dental work like root canal, we are recommending that you space that out, like wait for 3 to 4 weeks before you come in for surgery, because again, there's some relationship between the oral hygiene and infection. If the oral or dental work is an emergency, go get it done, but then you need to let the surgeon know so that your surgery can be rescheduled. If it's something that can wait, then wait until after your surgery so that you can take care of that dental work. Again, when it's done too close, it causes other issues, and that is infection, which is not good for you. We do have some antiseptic solution that will be provided, or you can buy this over the counter. An equivalent of that is called Hibiclens. Hibiclens, you can get it over the counter, and we recommend our patients to use that up to 3 nights before surgery. There are some medications you're supposed to stop taking up to 10 days before your surgery, and this is because this medication can cause bleeding. Medications such as aspirin, ibuprofen, Aleve, Advil, naproxen, those medications are called NSAIDs, non-steroidal anti-inflammatory. Our recommendations is that you stop taking those medications up to 10 days because, again, you don't want to have a risk of bleeding during your surgery. Supplements like vitamin E and fish oil have also been found to increase bleeding, and so is herbal medicines like ginkgo, ginseng, ginger, garlic, turmeric, all that listed there can increase bleeding. And here we are not talking about the spice, the one you use for cooking, the ginger or the garlic or the turmeric. No, we are talking of an actual pill. If you are taking any of those, then you might want to stop taking that up to 10 days. I hear someone asking, okay, if I don't take Aleve, what do I take? Because I'm relying on Aleve every evening. Well, you might want to switch that to Tylenol. Extra strength Tylenol, you can take that every 4 to 6 hours as needed for those 10 days, okay? Actual blood thinners like Pradaxa, Coumadin, Eliquis, Zoreto, you want to speak with the prescribing doctor so that they can tell you what to take for that time that you'll not be using those blood thinners. Okay, we are almost coming into the hospital now. Well, before you come into the hospital, you'll be getting a phone call from the pre-op nurse, and that happens the day before your surgery, between the time of 2 and 6 p.m. If you're coming in on a Monday, you'll be getting that call on Friday before. Please make sure that you have your phone next to you because the information that goes out from the pre-op nurse is very important, and that is going to include your medications. I would recommend that you make a list of your medications. What medicine are you taking, the dose, why you take it, and for how long you've been taking it. That's very important. And that list should include even the supplements that you're going to stop taking up to 10 days. So have a list of the medications with you as the call comes in, because that will save your time and the nurse's time. The nurse is also going to talk to you about NPO, when to stop eating and drinking. Things have changed. Some of you might be allowed to drink clear liquid up to 4 hours before coming into the hospital. Before, we used to keep our patients starving like for 10, 12 hours. Now, research has shown when patients come in so dehydrated and anxious because they didn't eat for so long, the outcome is now great. So the nurse might allow you to drink or have some clear liquid 4 hours before you come into the hospital. So this call is very important. Now, something she might not tell you, but I'm going to tell you, is that please do not come to the hospital constipated, okay? It's good for you to do some cleaning up before you come into the hospital because, unfortunately, the pain medications that are commonly used for the type of surgery that you're going to have, medications that are called opioids, the common side effect is constipation. Not too long ago, I had my patient coming in and he told me he hadn't had a bowel movement for 5 days. Well, that's not good. I can sit here all day long and tell you some horror stories about constipation that you don't want to hear. But I also have some sad stories about constipation, that people died as a result of the complication from constipation. So now we need to clean up. You need to have a bowel movement before you come into the hospital. Make sure you're not constipated. As a matter of fact, you might want to get yourself a laxative to use after surgery, because for as long as you're using the opioid type of pain medicine, then constipation is a guarantee. So add laxative onto your grocery list so that next time you go to the store, you get yourself one. CVS, Walgreens, they have an aisle with all the stuff. You can choose for yourself whichever you think will work better for you. What are you going to bring to the hospital? We said no skinny jeans, so we are going to bring something easy to wear, something comfortable. How about shorts and t-shirts? How about PJs? And for you who is coming in for neck surgery, you might want to bring a button-down top because it's a lot easier. And again, you don't have to bring a whole lot of those outfits because you're not going to stay with us for that long. If you have your brace given to you before surgery, you may bring it with you to the hospital. If you don't have one, don't worry about it. If you're coming for lower back surgery, because we do have the braces in stock. But for the neck, if you have one, bring it with you. If you don't have one, the surgeon would order one and you know where to get it for you. Leave your valuables at home and also medications. Please do not bring your medications to the hospital unless you have one of those rare medication that you also know is difficult to get, that you may bring. But other than that, you know, your lisinopril, your metformin or glipizide, we have that in our pharmacy. You don't have to bring them because they cause a lot of confusion. So please leave your medications and other valuables at home. If you have a sleep apnea, we want you to bring your CPAP mask and the tubing, okay? You don't need to bring your machine. We just need the mask and the hose, okay? And we also need to know the settings or the pressure on your machine or what pressure you are on at, you're using on at home. So please know the pressure on the machine. On the day of surgery, you're gonna check into this beautiful building. You see it over there on the right side. The address is 18,111 Brookhurst Avenue. And once you get into that building, as you walk in onto the right side, you do have the registration area. You're gonna get registered over there, and then they'll take you to the pre-op area where you're gonna meet with the surgeon and the anesthesiologist. Before you go in for surgery, of course, we're gonna put you in a gown for that time. You get an IV access because we need to give you some antibiotics, and this is given as a preventative measure to prevent an infection. So you'll get 3 doses of an antibiotic that will be given during your stay here in the hospital. Upon the time of going home, you don't need to continue taking these antibiotics. Okay, you're gonna meet with an anesthesiologist and the surgeon. I always tell my patients, this is a time for you to share with us that important information. about yourself that we know will help us improve your care here at the hospital. For example, the last time you had your gallbladder surgery many years ago, you have never forgotten how nauseous you got, Well, tell us, because probably the surgeon can, or the anesthesiologist can give you some anti-nausea way before, so that when you're going in for surgery and coming out, you're not as nauseous as you were at that time. The common side effect from the anesthesia is nausea and vomiting. So that piece of information is important. Or maybe you had some difficulties waking up from the anesthesia, or maybe they gave you some pain medicine that did not help you. So this is a time for you to share that information. And it's also another good time for you to ask any question, that you might have. Sometimes you go to the doctor's offices and, oh man, I forgot, I should have asked this. Well, that is not the end. You have another opportunity to ask a question in case you might have forgotten. So the anesthesiologist is going to review your health and medication history. They're going to discuss nausea and pain management concerns, and they're going to talk to you about the type of anesthesia, which is pretty much general anesthesia. And that means they're going to put you into sleep during surgery and give you some IV sedation. And of course, there's a breathing tube, and you might wake up with some sore throat because of that breathing tube, but that is a temporary problem. How long is your surgery? I don't know. It all depends with how many levels. Just like I said, a single level is easy breezy. Multi-level, we are talking of L1 to L5, could take a little bit longer. So on average, it could be 3, it could be 5 hours. It all depends with how many levels. All I know is sometimes even looking at the MRI is different than when the surgeon has opened and is doing the surgery. There could be something that was not reviewed on the MRI that he needs to address to that. So it varies. But for the purpose of the discussion, we can have it, for up to 3-4 hours. After your surgery, you're going to go to PACU, which is the recovery area, and they're going to put you there, just to monitor and make sure that the vital signs are fine. Make sure that you're comfortable, the pain is under control, that you're breathing okay. And while you're still there in PACU, your surgeon will be calling your family member or your coach to tell them how surgery went. You can't remember everything. The following day, the surgeon will be back to do their rounds, and they're going to talk to you and tell you how surgery went and give you a chance to ask any questions you might have. While you're still in PACU, the nurse is going to call your coach and let them know, of course, where they're going to transfer you. We are on 3rd floor. We try as much as possible to have private rooms for our patients. It's not a guarantee, but that's our priority. If we start on a busy day, we put you on a semi-private. Our goal is to move you to a private room later. Now, when you come upstairs, especially the following day, you're going to be complaining of pain. And you say, oh, nobody told me it's going to be this painful. And we will tell you, no, we told you, no pain, no gain. There's pain involved with your surgery. But by the end of the day, we want to get your pain under control so that you're able to eat, sleep, and move. So how do we understand your pain? Because pain is very subjective, We do have a pain scale tool. And this pain scale tool kind of helps us understand your pain. We'll be asking you, on the scale of 0 to 10, 10 being the highest, how bad is your pain? Some of you will be up to 20. I don't see it on the scale, but we want you to tell us as it is. Our goal is to keep you to less than 4, because research has shown that most people can function with a pain of less than 4. Anytime we go up to 5, 6, and 10, people get so mean, they become little monsters. So we'll do whatever we can to get your pain down to 4. That means switching your medications, calling the doctor for that. It means maybe calling pain doctor. We will do whatever we can to get your pain to your comfortable level. The following day after your surgery, the orders we have from your surgeon is to get you up on the chair. recliner that I have there is kind of a fancy recliner. We are getting new ones, but this is what we have at the moment. You can see the fanciness. It does have the wheels, and it has the tray on the side. So the CNAs will come to get you up all dressed in your own clothes between the time of 6 and 6:30, ready for breakfast, ready for the surgeons to come and do his round, and ready for physical therapy. So please be compliant. Sometimes you come in and patients say, oh, I want to sleep in. Oh, wow, you sleeping in the hospital is not very possible sleeping in, because you'll be left behind the schedule. Please be compliant. Getting up is for your own good, and being active in the program and participating is a good thing for you. But we'll get you up on this chair. Actually, most of our patients prefer to stay in this chair and to sleep in this chair because it kind of reclines into a bed. And you might realize it's a lot easier to get off of that chair than from the bed, because you're going to have some precautions or some things you can and cannot do. And that doesn't make it very easy for you to get up or get out of that bed. So that is going to be your best friend, the recliner. And again, this chair can recline into a bed. If you want to take a nap, then of course we can recline it so that you take a nap during the day. All the staff in our unit, that is the PCA, and the nurses have all been trained on how to take care of a spine patient. There are some complications that are associated with your surgery. And number one, just like I talked at the beginning, is a clot. The medical term is DVT, deep venous thrombosis. And that means you have a clot in your calf area or in the small veins to the back of your leg because of immobilization. That's why I said get up and move, because that activity helps with the circulation. Instead of the blood pooling and stagnating in your veins, when you get up and move, then you are able to prevent yourself from getting a DVT. If that clot loosens and then it travels in the bloodstream, it could cause a blockage in your lungs, and we call that pulmonary embolism. That's not good. Simple to prevent: getting up and moving. Doing your ankle pumps, that's very important. We also have some squeezers that we put in the legs that is connected to a machine. It will be alternating the pressure on opposite legs. I call it free massage. It feels so good. It squeezes, tightens one side, releases and tightens on the other side. We call that an SCD. You might have the TED hose. The TED hose is a surgical stockings. They are white normally. If you find those stockings on your legs, again, it's because we are trying to prevent a blood clot. Infection, how do we prevent that? Well, we're going to have you use the Hibiclens or an equivalent. Any antiseptic soap or solution that you can use before your surgery is appreciated. And you're using it all over your body. Most of them have the instructions in the packaging. If you have any issues in getting one out there, you may call me, and we do have a special one, or another one that we use here at the hospital is called chlorhexidine. Nausea and vomiting is not unusual, especially if you have motion sickness. I would tell them in the pre-op so that they can give you some anti-nausea medicine. Sometimes it comes in the form of a patch that is put behind your ear. So please tell them ahead of time. When it comes to lower back surgery, especially if they go through the front, we call it anteroposterior, they go through the front and the back. There's usually a concern of that abdominal distension. We call it an ileus. It means the gas is trapped in your bowels, and that's not fun. One way of preventing that, guess what, is ambulation, getting up and moving. When people pass gas, our patients here at the hospital, we throw a party. So we want you to tell us when you pass gas. In fact, our good mornings, when you come to see you in the morning, it's like, did you pass gas? Well, if you haven't passed gas, they might want to keep you on ice chips only or just clear liquid. So it's very important that you pass that gas, because if you don't pass gas, then it's another complication that they might have to put a tube through your nose to decompress. We call it because of that area. So it's very important that you get moving. We'll give you some stool softeners to get everything moving, but more than anything else is really activity. However small the activity or little the activity is, whether it's just getting out of the bed to the chair, moving, walking to the toilet and back again, that will facilitate the gas thing. So very, very important. Constipation, yes, I talked to you about constipation and I told you what to do. You're going to get yourself a laxative. Here at the hospital, we have them ordered already, but my concern is for you after you leave the hospital because the stool softeners don't carry it. You might need something stronger like Miralax, Metamucil. CVS have these, or most of them has this tea, it's called a smooth move. You know, they have a variety of laxatives that you may use. Getting up and moving, yes, our physical therapist will tell you like every 30, 35 minutes, you want to get up and move around. Diet is very important, high fiber diet, more of the, dried fruits, things like salads are so good as well to get you regulated and also staying well hydrated. For the sore throat, we see that with patients who are coming in to have neck surgery. Number one, because of the nature of the procedure itself, is to the front next to the to your throat, and also because of the breathing tube. So you might have some soreness. What we want you to do is to, have enough of those soups at home because that's what you're gonna be eating pretty much for the first 7 days. Or you want to eat some soft food like mashed potatoes with a gravy, something easy to swallow. You may use some throat lozenges that you can get that over the counter. And again, this is a temporary problem. On average, most people will have this problem resolved in about 7 or 10 days. We just want you to be aware so that you can, have enough of those soups at home. Pneumonia is common, and how to prevent that, we provide an incentive spirometer. We do have it on the right side. I believe you might have seen that blue apparatus. It has something that you put in your mouth and you inhale, okay? Before, we used to have those ones that you blow into, not this kind. This kind, you put it in your mouth and you use this as a straw. You suck it in slowly and hold your breath for a count of 4 and remove and breathe out. Or maybe you'll be doing your cough and deep breathing exercises. Even before you come into the hospital, you want to smell the roses and blow the candle. That is good for your lungs. Now, I don't know any one of you, but smoking is not a good thing, especially with the type of surgery you're going to have. You've made the right decision. Go all the way and quit smoking, because if you don't, you're more likely to get infected if you smoke. You're more likely to get pneumonia, and you could have a heart attack and die. We do have some numbers listed there. You can call this number, or you can go to the website and get some information to support you so that you can quit. We cannot make the pain go away completely. We'll manage the discomfort so that you can eat, sleep, and move. That is our goal. And of course, sometimes the nerve pain persists after surgery, or it could even get worse. And it's like, oh, surgery did not work. Well, before you make that conclusion, just know it could take some time before everything comes back to normal. We've had patients who will wake up from surgery and it's like, oh, the numbness, the tingling, everything is all gone. I feel good. Well, that's not the case for everybody. For some, it's like, ouch, I have some pain that was not there before. Well, that doesn't mean that surgery has failed. We just need a matter of more time, probably with physical therapy that will be ordered at 4 to 6 weeks after your surgery. But we just wanted you to be aware of that. The following day after surgery, if you ever had a PCA, remember I talked about the pump with all the medication that you medicate yourself. We don't see that quite often, but if you ever get one, just know that we are coming to get rid of it the following day. And if you have it and you don't want to use it, you don't have to, because there are other medications ordered in small doses. So if you have a PCA and you feel, oh, I don't want to use the PCA, is there another option? Well, tell the nurses, because there's always another option. You just don't have to use it because you have it. If you have a folic catheter, and I say this is really for people who are coming in for lower back surgery. If you're coming in for neck surgery, there's no reason you should have a Foley. So if you have a Foley catheter, it comes out the following day at around 5 a.m. so that by the time the physical therapist is coming to get you up, you can go to the bathroom and void. We want you to be on oral pain medication versus IV. We do have intravenous pain medications, but we want to use them for breakthrough pain management. What that means is your pain on the scale of 0 to 10 was about 6. And I gave you some hydrocodone. And then I'm coming 1 hour after, we are still at 5, or even we went higher like 6, then yes, I'll give you some IV pain medication. But for the most part, we want to maintain you, or the pain is better managed with the oral pain medications. The IV kicks in first, but it wears out first. So really, you want to have the IV pain medication to be used just for breakthrough pain management. I wish we can manage your pain with non-opioid pain medications like Tylenol, but it's not always very possible. So we might have to use those opioids just for that time. And again, the common side effect, like I told you, is constipation. The types of pain and discomfort you're going to experience, it could be anything. Of course, incisional pain because you had a cut on your back or on your neck. It could feel like soreness or some pressure, and we treat that with medications. You might have spasms, and maybe some of you are having some of these, symptoms at the moment. Muscle spasms, you have nerve pain. Well, the muscle spasm feels like tight grabbing sensation, and we treat that with muscle relaxant. The nerve pain will feel like numbness and tingling that will be shooting, feels like heart pain. And again, we do have medications that we use for treating the nerve pain. So many options, and maybe some of you are already taking those medications. But besides all that, we do have what we call cold therapy. Cold therapy, as you can see onto your right side, is a frozen gel that you put in a container, a wrap. And that wrap, you can put it on your back or you can use it on your neck area. Most of our patients love it. You're going to get 1 wrap and 2 sets of gels so that you can switch throughout the day. You really want to make ice your best friend. It does help with the pain. It does help with the inflammation. Change of position is always very important. Probably by sitting down all this time, your body is telling you to get up and move, move, move. Well, we want the same thing for you here at the hospital. Walking time is any time for us. If it's in the night and you've been in that bed, you feel like you need to get up and stretch a little bit, or you want to sit up on the recliner, the CNAs and the other staff members are more than willing to help you get up and reposition, or get up and walk, or even reposition. Maybe you're sleeping on your back for so long and it's time to sleep on your side. Tell the nurses and they'll be there to help you so that they can facilitate your pain management. We want you to ask for pain medicine when the pain starts. Don't wait until it's too late. Some patient is like, I'm going to wait and see how it goes. Well, it's just going to get worse. So when the pain starts, it's the time for you to ask for the pain medicine. Don't wait for so long. We normally have boards in the room because sometimes you might forget, the last time you took your pain medicine. Well, we communicate via boards in the room, and the nurse can write there for you and let you know the last time you took your pain medicine so that you know when the next dose is due. We want you to take your pain medicine on a regular basis. And of course, tell the nurse if the medication is not effective, and be sure to understand your pain management efforts that we have in place for you. So we are concerned about your safety here at the hospital. We really don't want anybody getting out of the bed or out of the chair without assistance. So please call. We don't want anybody falling. We respect your privacy. Sometimes, the patients will be up. I'm talking about men. Here at the hospital are men who are above 65 years, just don't want anybody next to them when they're using the urinal. And that's not good because we are concerned about your safety. I can see you, you're up and walking okay, but because of the Norco or the Percocet, you might lose your balance, get dizzy, and you might fall. So we are very keen on that, and that's why our CNAs are going to stick with you there. Look at the other direction just to make sure that you're okay. We don't want you falling. We value your privacy, but safety comes first. So please don't kick the CNAs out of the room. We have all been educated, and we want safety for our patients. I had a patient that had knee surgery, and he got up okay, and he was using the urinal, and he told the CNA to step out of the room. And the next time we had a thud on the floor. Well, good thing is he did not damage his knee surgery, but he dislocated his shoulder. It's not worth it. So please bear with us for the time that you are here. We just want to make sure that everything is okay with you. We love coaches. Your coach is the person, it could be a friend, your child, a family member, someone that will be there to assist you during your recovery, to provide comfort and motivation. And they can be here, work with the physical therapist so that they see how things are being done, probably getting in and out of bed. How do you go upstairs, downstairs? Is good for that person to be here. And our physical therapists are very flexible. Depending on what time your coach is available to come in, they can work with you so that we can show them or show your coach the things that needs to be done and how they need to be done. Our visiting time is between the time of 8 and 8 p.m., 8 a.m., 8 p.m., and we allow 2 visitors at a time. So again, the role of the coach is to assist with mobility, encourage and motivate, and of course, observe and make sure that everything is okay. After you leave the hospital, we want you to continue taking your pain medication as prescribed. Take your stool softeners and also take your laxatives because the stool softeners don't cut it. We want you to wean off the opioids because we have a national crisis right now with people getting addicted. But you know why? It's because they abuse those medications. What do I mean by abusing the medications? Well, on the scale of 0 to 10, your pain is just a 3. Why are you taking Norco? Just because you have it? How about you change your position or maybe use some ice pack or take Tylenol? You don't have to use the pain medication just because you have it. So please wean off those medications, cut off. As you continue to heal, get yourself off of those opioids because it's not a good thing for you to get addicted. Avoid Motrin, Advil, and aspirin type of medications. Those are called NSAIDs, non-steroidal anti-inflammatory. Remember you talked about that before coming to the hospital? Well, even after surgery, you didn't have to wait until you get an okay from your surgeon to go back to those medications because they could interfere with the fusion. So try or stay away from NSAIDs, non-steroidal anti-inflammatory. The decision for you to go home is made by everybody in the team, including you. And our goal is for you to go home. You're either going home with home physical therapy. Sometimes patients will say, well, I live alone. I need to go to one of those care centers. And we are telling you probably that's not a good option because these stories we hear from those nursing homes is not very good. And worst of all is that you're more likely to get infected in one of those places. I used to work in a nursing home. I did that for 14, 15 years. Would I want to put my loved one there after surgery? No, not really. The people who are there need to be there. For you, because you have enough time, maybe you live alone, you can call up one of your friends to hang out with you for about 4 or 5 days. You have been there for them all this time. They can come in for you this time when you need help. So please plan on going home. The insurances are very keen with the request for skilled nursing facilities because they don't want you going there. We've had patients saying, oh, well, I went there before. My insurance said I could go there. Well, Alisha will tell you we've had issues where the insurances denied it, and you telling them that you don't have a person at home is not a good reason, simply because you had all the time to plan. This is not an emergency. You are listening to the class today so that you can prepare yourself to return to your own home. And I think that's a good environment for you to recover in. Okay, Alisha, it's your turn.
Hi, so I'm Alisha from physical therapy. Most likely it will be me seeing you when you come to the hospital for your spine surgery. Like Winnie has said before, our goal is to get you up the day of surgery. Now, that does depend on what time your surgery is, though. So if your surgery is in the early morning, expect us to come in the afternoon to check on you. But if your surgery is in the afternoon, then it's less likely that we will be able to see you and that you will be awake enough and ready for activity before we leave for our day. Like Winnie said earlier, though, all of our nurses and our PCAs are trained in how to assist you out of bed with your spine surgery. And so you are able to get up before seeing physical therapy. Now, if you have an earlier surgery, like I said, our goal is to get you up the day of surgery. That looks different for everyone, just like every surgery is different for everyone. So some people are able to get out of bed, sit at the edge of the bed. Some people are able to stand, and I do have a fair amount of people who are eager to walk, and we walk down the hallway a little bit, but we tailor it to whatever you are able to tolerate that day. We also always make an effort to make sure that you have had pain medicine before we get you up. Because you will have pain, we try to make it a little bit easier and coordinate everything. So like this says, the day of surgery, we'll be getting you up, but the day of surgery, we will not see you 2 times. The following days, we might see you twice a day, depending on what your needs are with therapy and where your mobility is at. What that looks like when you're in the hospital is getting in and out of bed, how to get in and out of a chair, doing stair training if you need it, car transfers, and we can discuss any type of specific needs you have. Some people have a very tall bed, and we can kind of mimic that while you're here as well. But it's all about functional mobility while you're here in the hospital. If we're able to get you home, which is our goal, we want to make sure that we can practice a lot of these things in a controlled environment before you leave and answer as many questions as possible. So the spine precautions for our low back surgery are no bending, lifting, or twisting, so no BLTs. Essentially, your shoulders and your hips need to face the same direction when you're doing any type of activity. For our neck surgeries, it's a little bit different. Similar in that we don't want you bending, we don't want you lifting, but it's more geared towards overhead lifting as well, and being very mindful of your neck positions. Every surgeon is a little bit different, so we will go over the specific instructions from your surgeon, since every surgery is different, but these are the general precautions that we go over with our patients. So occupational therapy, you might have occupational therapy come see you in the hospital while you're with us. They go over activities of daily living. So getting dressed, bathing, brushing your teeth, doing activities at the sink, and different ways that you are going to have to be doing things in your daily life and modify things a little bit. So when the occupational therapist comes, often they bring a hip kit. It is something that is sold at the gift shop in the patient care pavilion, the tall building that you'll come into the morning of your surgery. And in the gift shop, they have a kit which has a long-handled loofah, a reacher, a sock aid, and a long-handled shoehorn. I believe it's about $22 and tax. It's something that we just have there available at cost for you to use. It makes life a lot easier after your spine surgery. And if you do think you want components of it, or you are interested in it, we can go over training with that, either the therapist, the physical therapist, or the occupational therapist, whoever you are seeing. We can talk to you about it and see if it might be useful for you. One thing that we do always recommend, though, is a reacher, because even if you might not use all of the items, a reacher is a really helpful thing to have, just for something falling on the ground or something you want to get that's outside of your reach that you would normally maybe bend over a little bit or twist to get. It makes life a lot easier, and it gives you a little bit more independence after surgery. So that's something we recommend for everyone. So braces, what we suggest is that you check with your surgeon or your surgeon's office about a brace ahead of time. If you are having a back brace, some surgeons prefer their back brace that they have from a specific vendor. But you would need to check that ahead of time, because once you come to the hospital, we would be issuing our back braces that we will fit to you and discuss with you, train you on how to use those. And if you come with an outside brace as well, we will do the same thing. Make sure you understand how to use it, when to wear it, all of those things. The other brace in the picture is a brace for a neck surgery. If most of the time, if you need a brace after your neck surgery, you will come up from recovery with that brace. And these are all just good questions to ask the office ahead of time, because sometimes for the neck brace as well, they send you somewhere that you would need to be fitted, and they would go over some things with you, which we can follow up as well when you're here. So equipment, majority of the time, we will use a walker for our first time up out of bed. That doesn't mean you'll necessarily need a walker to go home, but it is a safety thing, especially after anesthesia and you're having a little bit more difficult time getting around because of pain. So we usually start using a walker, and then we'll have a discussion and more time to see if you'll need one when you go home. A lot of times now we're finding that insurance usually only covers one item. And so we will likely recommend a walker for a lot of our back patients. For the neck patients, not as common though, but it just depends. The other item that you see pictured is a bedside commode. That's something that can be very, very useful after back surgery. Say if someone wasn't super mobile and at night, you could put it next to the bed, so you wouldn't have to go as far of a distance. Or else, one common thing we recommend is for someone to put it over the toilet at home. It just makes things a little bit easier because it'll be a higher height, and then it also has handles to push off of. So we'll discuss all these options for you and what your specific needs are while you're here in the hospital. If we do find that we recommend equipment for you, we will work with insurance to see if we can get it covered. But like I said before, most of the time, insurance is only covering one item. So preparing your home is a big part of the recommendations that we make before coming to the hospital. It's very helpful for you guys to set that up now ahead of time. One big thing is to remove throw rugs, especially if you have anything in the bathroom or the kitchen. You are a fall risk going home from surgery, even if you're not using a walker at home, still being on any type of pain medication. So we recommend the bathroom, the kitchen rugs, to remove those if you have any. And then also in your home, if you have any throw rugs that you sometimes catch your foot on, or that wouldn't allow you to have a wide enough space for you to safely move through, we recommend that you kind of look at those things ahead of time. It will make for a much smoother recovery. We haven't had anyone need a special bed for home. Some people do ask about hospital beds. Commonly, hospital beds are not covered by insurance, but it is a rental option. If you do have a bed at home that you have some questions on, or a specific setup, we can definitely practice that here. And we can also mimic the bed height, since our beds go up and down. I have had people purchase rails at home that you can buy from Amazon. It goes under your mattress, and that is something that people have found helpful. But generally, we just recommend using your own bed. The other option is a recliner chair. Our surgeons have deemed that to be an appropriate place to rest for a longer period of time. And so recliner chairs are a good option for sleeping in, even sometimes if you're having more difficulty getting in and out of bed. It's a very nice thing to have available to you. If you do not have a recliner chair, I really would recommend that when you are resting in the house, you kind of think of where you're going to sit throughout the day, and you would ideally want something with armrests. It gives you some better leverage to push off, because after your back surgery, it is more challenging. Sitting and standing is a little bit more uncomfortable, and you are relying on your arms a little bit more. Another thing you want to think about is food at home. If you do not have someone who's going to be with you a lot of the time, even though our goal is to send you home, you're walking, you're moving around, you may not tolerate preparing food, standing at a counter for a long period of time. So it's nice to have some quick, easy options. So frozen meals are something that we would really recommend. And then also, if you have pets at home, you really need to see if someone can help you with them. Even if you are able to walk, we do not recommend you holding on to the leash. You know, animals can be unpredictable, and if they jerk you or have some weird motion, you know, that's not good for your back and your recovery. Also, when you're taking a walk, you do have to clean up after your pets, and that's something that's going to be more challenging as well, especially with uneven surfaces outside. So we do recommend that someone helps you with that during your recovery. So recommendations at home. Walking is going to be your main form of exercise. You want to slowly and steadily increase that, kind of pay attention to your body, see how you're feeling for the first time. But that will be your main form of exercise until your surgeon says otherwise. You need to be mindful about your spine precautions, no bending, lifting, or twisting, and how to do, you know, your normal activities at home. If you have a concern about doing something safely, I'd be happy to go over it with you. Also, if you have stairs, we will practice those while you're here, but we do not recommend that you're doing them more than just at the bare necessity, meaning going upstairs to go to sleep at night and then using the stairs to come down in the morning. Like I said before about the rugs, you are a fall risk. And so limiting that use to only the necessities is our recommendation in the beginning. If you do have home health therapy, they can also practice stairs with you and make sure that you're doing those well and in the safest options for you. If you have a brace that you're going home with, we'll make sure to inform you of when your surgeon recommends you wearing it and how. But the biggest goal is that you're up and walking daily and that you're changing position often. Most of the time we recommend that you're up and moving every hour. And so it's kind of like the first thing you wake up in the morning and you're sore from laying in that same position all night long. When you are in a position throughout the day, you do get more stiff, more uncomfortable. And so if you are up and moving every hour, that makes things a little bit easier and usually helps with pain and comfort as well. So outpatient physical therapy, everyone is here or listening to this because they've had pain, they've had some type of issue going on for a period of time. We want to make sure that you have a very good long-term recovery. And with that, we recommend outpatient therapy. It's not something that would be started right away. It would be something that would be started once your surgeon clears you, weeks after your surgery, usually when they decide that your precautions are lifted. But especially if you're someone who wants to get back to gardening or a specific activity or to go back to work, for a good long-term recovery, you want to make sure that you're doing all of those motions, those activities safely, and outpatient physical therapy could guide you through that progression and make sure that you're protecting your back while you're engaging in the activity again. So some exercises that you can work on ahead of time. The one called the chair raise is really good because you're going to be relying on your arms a lot more during your recovery. So it'd just be seated in a chair and using your arms to push yourself up. You can try doing that 5 times, 10 times. Some of these exercises, they should be tiring, but it shouldn't be very, very painful for you. If it is, please stop and don't do them. These are just general recommended exercises that you can do ahead of time to help with your recovery. The next exercise is a long arc quad. You would be seated in a chair with your feet on the floor, and you would do one leg at a time. You would lift your leg up straight as you're able to, hold it for a count of 3, and then come back down slow and controlled. This one as well, if you're able to do 10 on each leg, just strengthening things a little bit before your surgery. So another great one is the quad set. You could do it maybe laying in bed before you get up. You're essentially just pushing your knee down into the bed. So the muscle above your knee, the quads, should be activating. You'd be holding that for a count of 1, 2, 3 again, and relaxing. And you can do 10 as well. You can do both legs together or one at a time, depending on how you feel. Another one that you can do in bed or on the floor, depending on how your mobility is. It's called the posterior pelvic tilt. It'd be very good for the back patients. It's kind of when you are, if you had your hands on your hips, you're tilting your pelvis back a little bit, flattening your back against the floor or the bed, whatever you're on, so that there's not a little gap in your back, but it's very gentle. So you're just bringing your hips back, flattening your back a little bit, and contracting your abs. And you can hold that for a count of 3 as well, and then relax just to try to get that abdominal engagement. So discharging home. If you do have a long drive, be sure to mention that to your therapist. We can give a few different strategies for that, but we also will talk about, car transfers, getting in and out of the car, and talking about your specific car so we can problem solve a little bit. But the biggest thing is that if you do have a long drive, our recommendation is to get out every half hour or hour so that you can get out of the car and move around. I understand that that's, something that could happen living in Orange County, but we have different recommendations in terms of changing the seat position, and just getting out is the biggest recommendation. So that is it from us. Thank you so much for coming, and we will see you soon.